Assalamu alaikum. Thank you for the kind introduction and the organizers for the kind invitation. I'm honored to be here today. And Dr. Khalid, you made my task really easy because you highlighted the importance of screening for treatable disorders, which I will highlight in my talk, inshallah. So I'll talk about the approach to the investigation of children with neurodevelopmental delay, a metabolic and genetics perspective. So I have nothing to disclose. The outline of my talk will include first reviewing the definitions and epidemiology of global developmental delay and intellectual disability. Second, highlighting the diagnostic challenge and importance of actually identifying the etiology. Third, to review the recommendations which are available for testing, including screening for inborn errors of metabolism in children who have global developmental delay and intellectual disability. So let's start by reviewing some of the definitions. So what is global developmental delay? This is defined as a significant delay, more than 1.5 standard deviation below age expected norms in 2 or more of the following domains. So this will include gross and fine motor skills, speech and language, social and personal skills, activities of daily living, and lastly, cognition. And this definition is usually reserved for children who are younger than age of 5 years. While intellectual disability is reserved for those above the age of 5 years, and it is defined also using a couple of domains, which include the IQ, adaptive behavior, and the systems of support that are afforded to the individual. So intellectual functioning level or IQ less than 70, in addition to significant limitation in 2 or more adaptive skills. And we all know that intellectual disability is often associated with other comorbidities, including behavioral problems such as autism, hyperactivity, aggressiveness, self-injury behavior, epilepsy, and other neurological disabilities. So the classification of intellectual disability, I think all of you are well aware of this. So this is according to the IQ, in addition to the degree of the support that is required for that individual. 85% of intellectual disability is actually the mild, which is defined by an IQ of between 50 to 69. These individuals usually can live independently with minimum level of support, and they require support during transitions or periods of uncertainty. While moderate intellectual disability comprises only 10%, the IQ ranges from 36 to 49, and they require more support with independent living. And so on and so forth with the severe and profound severities of intellectual disability. So how common is it? So it's actually very common. 2 to 3% of children and adults worldwide have this problem. Intellectual disability, we all know, is common, and it's associated with the highest lifetime healthcare and economic costs of any disease, nearly equaling actually the economic impact of stroke, heart disease, and cancer combined. And in addition to that, it causes significant psychological and social burden. It's associated with problems later in life, such as learning difficulties, behavioral problems, and functional impairments. So we are faced with a diagnostic challenge. It's a common problem. However, there are a large number of etiologies in terms of the causes of global developmental delay intellectual disability. And a differential diagnosis includes, but is not restricted to these listed here. So infections and drug toxin exposure during pregnancy should be looked into and excluded. Perinatal complications such as hypoxic ischemic encephalopathy, neonatal complications such as meningitis, and then the genetic abnormalities, which actually represent the most frequent cause. And these can be divided into chromosomal, single gene, or methylation abnormalities. Then come the inborn errors of metabolism. And lastly, trauma, maltreatment, and neglect. So what are the benefits of establishing an etiological diagnosis? So we all know that providing a clarification of the etiology is something important, and this will provide information on prognosis and expected clinical course over time. We can also discuss the genetic mechanism and thus the recurrence risk with the family, which is especially important in our population with consanguinity and a high incidence of autosomal recessive conditions. We can also provide refined treatment options based on the etiology. We can definitely avoid unnecessary redundant diagnostic testing. We can provide information regarding the treatment, symptom management, surveillance for known complications associated with this condition or etiology, provision of condition-specific family support, in addition to access to treatment, rehabilitation, and also possible research treatment protocols, especially in this era. It also offers the opportunity for co-management of patients in the context of a medical home to ensure the best health, social, and healthcare services for the child and the family. So how about the patient and family perspective? Do they actually want to know the etiology? So Makila et al. Studied in depth this question. So they grouped 20 families of children who have intellectual disability, those with and without an etiological diagnosis. And they asked specific questions, stated the needs and feelings about what a genetic diagnosis offers. So first of all, they mentioned validation. So a diagnosis established that intellectual disability was credible, and this empowered them to advocate for their child. Secondly, it provided information. So a diagnosis was felt to help guide expectations and management and provide hope for treatment or cure in the future. And thirdly, procuring services, which is especially important. So the diagnosis assisted the family in obtaining the desired services, particularly, for example, in schools. The need to know, families widely differed. So some of them strongly believed that they wanted to know, and some were indifferent. But this just highlights this aspect from the patient's and family's perspective. So let's highlight a single case in order for us to understand and discuss the approach. So this is Nathan. He presented in infancy with poor feeding, hypotonia, and delayed psychomotor development. We have to also consider that everything previous was normal, so there was no perinatal complication. Family history was completely negative. There was no history of consanguinity. He continued to have delayed development. So in early childhood, he obtained some milestones. So he walked and said his first word, first at 3 years of age. He was also assessed to lie on an autism spectrum. And this diagnosis was very unclear for the family. At the age of 5.5 years, he had a confirmed assessment of mild intellectual disability. In addition, he had severe language delay with oral motor dyspraxia and clumsiness, and he also had one episode of an afebrile seizure. So keep this patient in mind, and we'll go to the approach. So what does the literature tell us? So let's go back in time and see what has been published in this regard. So first, the American Academy of Pediatrics published this clinical report on the comprehensive evaluation of children with intellectual disability or global developmental delay. They emphasized the importance of understanding the etiology and also especially the treatable causes. They emphasized that all children should have a very thorough and complete detailed history, including perinatal, birth history, family history, including a 3-generation family pedigree. And I have to highlight that in our population, this is even more important, given the consanguinity and high incidence of autosomal recessive conditions. So the family history can really help you. In addition to that, you have to do a thorough and detailed physical exam looking for minor anomalies, including neurocutaneous findings, and then do a detailed neurologic and developmental exam. Following all of this, consider investigations. So let's see what they recommended. So the first line investigation in terms of genetics was chromosomal microarray, in addition to Fragile X testing, with or without screening or genetic testing for Rett syndrome. And then they also mentioned that the physician has to consider certain other investigations judiciously based on the clinical features. And this included metabolic testing to screen for inborn errors of metabolism with or without a brain MRI. So this is the flow of the report. So first you start with the comprehensive family history, medical history, neurologic exam, and physical exam with dysmorphology, focus on dysmorphology. If you suspect a diagnosis based on your initial assessment, you can do confirmatory testing based on your suspicion. However, if you do not suspect a specific diagnosis, you go towards the other path, which includes, as I mentioned, a microarray, Fragile X testing, and to consider the first tier of metabolic investigations, which I list here. And based on that, if you have a confirmatory diagnosis, you will go towards the counseling and initiation of the management for the patient and his or her family. However, if there's no diagnosis established, you have to move on to further testing. And this is a long list, which includes gene testing and brain MRI. And of course, if the diagnosis is not established based on that, you have to review your history and consider referral to a geneticist. So what's the evidence that is available to support screening for metabolic disorders specifically? We already know and highlighted by Dr. Khaled in his previous talk that inborn errors of metabolism are uniquely amenable to beneficial causal treatment. And this is defined as a medical intervention that is targeting the underlying defect and the pathogenesis. So these treatments can include dietary restriction, supplementation with cofactors, enzymes, or vitamins, substrate inhibition or reduction, enzyme replacement therapy, bone marrow transplant, and it's on the horizon, believe me, gene therapy. So based on a number of published studies, the range of inborn errors of metabolism as a cause of intellectual disability was estimated to range from 1 to 5%. So as you can see, it's not high. It's actually a low incidence compared to the other causes. And this large variation in the published studies was based on the location, the age range, the time frame, and also the testing protocol. So why does it matter to screen for inborn errors of metabolism? We always kind of re-emphasize that the majority of inborn errors of metabolism are treatable conditions. We all know that newborn screening provides only a detection of a certain number of conditions, and this varies from country to country. The newborn screen, remember, is only a screen. Even if it's normal, you have to proceed with diagnostic testing if you have a clinical suspicion. So testing is not without its own challenges. We know that global developmental delay, intellectual disability is common. As I highlighted, inborn errors of metabolism are considered rare. There's a wide range of inborn errors of metabolism. The potential list of investigations is very long and may be expensive. And there is also a potential for false positives. So let's review some of the papers that discuss this. So the first one is the etiology of mental retardation in children, referred to a tertiary care center. So this was published by Clara Van Karnep in 2005. It was a prospective study. So they recruited consecutive patients from 0 to 18 years that were referred to clinical geneticists at a tertiary academic center with unexplained intellectual disability. And they recruited 281 patients. They developed a protocol for testing of all patients, and they grouped them into a probable diagnosis versus no evident diagnosis. They did metabolic screening in all patients with no clear evidence of a diagnosis, and they did this list of investigation. The diagnosis was established, interestingly, in more than half actually of these patients, so 53% achieved a diagnosis based on their algorithm. The diagnosis in 2/3 of patients was provided by a detailed history and physical examination. A metabolic disorder was diagnosed in 4.6% of patients. So again, a small number. The second paper, the same group in Netherlands in 2012, followed up this study. And this time they aimed to design an evidence-based protocol for the diagnostic evaluation of genetic causes with the premise to consider treatable inborn errors of metabolism at the outset. So they called this the treatable ID endeavor, or the TIDE approach. So they did actually a literature review to identify inborn errors of metabolism that have global developmental delay or intellectual disability as a prominent feature. In addition, the condition had to be amenable to therapy. And with this review, they identified 89 disorders, and they list them here. And the level of evidence for the treatment also varied. And based on that, they characterized clinical and diagnostic evaluation patterns, and they outlined a 2-tiered approach to testing. And this was targeted for developmental pediatricians, geneticists, and neurologists. So this is the first tier, non-targeted screening. which identifies 60% of treatable inborn errors of metabolism. So as you can see here, it's a very long list: ammonia lactate, plasma amino acids, total homocysteine, acyl-carnitine, copper ceruloplasmin, in the urine, organic acids, purines, pyrimidines, creatine metabolites, oligosaccharides, and glycosaminoglycans. So this is done for all of the patients. The second tier test is based on the differential diagnosis generated by the patient's signs and symptoms, and they highlight that you should order it with a low threshold. And this is a very long list, as you can see here, and they mentioned that it diagnosed the remaining 40% of the treatable inborn errors of metabolism that they highlighted in their literature review. So this is available as an application that you can easily download, a treatable ID. You can plug in the signs and symptoms. It can give you what testing to order, and then what are the differential diagnoses. So sometimes these tools can be useful. However, you have to rely on your knowledge as well. So the third paper, it's actually 9 years after the initial one. So this is in 2021. They updated the literature review, again, including all the reports on the treatable intellectual disability published from that time, from 2012 to 2021. And they increased the number of treatable intellectual disability disorders to 116. So the number of disorders increased by more than 1/3 in 8 years. So the data on clinical symptoms, diagnostic testing, treatment strategies, and outcomes were evaluated. And based on that, they generated the knowledge, and this was translated into a diagnostic algorithm, updating the application with novel features. So the most frequent therapeutic interventions that they highlighted were nutritional, pharmacological, and vitamin trace element supplementation. The reported effects included improvement in the clinical deterioration in 62%, improvement in neurologic manifestations in 47%, and improvement in development in 37%. So we all know that there's a lot of emphasis on gene-based therapy, enzyme replacement therapy. However, they mentioned that the majority of the effective treatments were actually nutritional, relatively affordable, widely available, and surprisingly effective. So this is the updated algorithm. So what changed from 2012 to 2021? They added genetic testing. So after you do your history and you identify that this is a child who has unexplained developmental delay or intellectual disability, you go on to do parallel first-tier metabolic investigations in addition to genetic testing. So this actually made a big difference. So the prioritization of the exome sequencing in the diagnostic algorithm aided in the higher yield of diagnosis for these patients. You have to keep in mind, however, that these techniques, genetic testing, is not always available or easily accessible. It has a significantly longer turnaround time compared to conventional metabolic screening. Around 40 to 50% of patients actually undergoing genetic testing for intellectual disability remain undiagnosed, which still makes metabolic screening an important part of the diagnostic workup, and as they suggested, has to be done in parallel. So it seems reasonable to initiate metabolic screening and genetic testing in parallel. So what about 2022? Do we have any updates? Actually, yes. This paper was just published in September 2022. So individuals with intellectual disability and neurodevelopmental disorders are currently investigated with different approaches in clinical genetic diagnostic centers. So in the study, they actually compared the results from 3 different diagnostic pipelines in patients with intellectual disability. The first group was first-line whole genome sequencing, 100 patients. The second group was genome sequencing as a secondary test, 129 patients. And the last group was chromosomal microarray with or without FMR1 analysis for Fragile X. And this comprised the largest group of patients of 421. So let's look at the results. So not surprisingly, the first group who underwent whole genome sequencing as a first-line investigation achieved the higher yield of diagnostics. So 37% achieved the result. Compared to the second group, the secondary test was whole genome sequencing, achieved the diagnosis in 26%. And the last group, which is the standard screening, who underwent only a chromosomal microarray with Fragile X testing, Actually, the diagnosis was reached in around 12% of patients. So they highlight that genome sequencing as a first-line investigation is valid. It is time and cost effective and also a sensitive method. So back to our patient case. So remember Nathan? So he underwent actually this algorithm. So the physicians did the first-tier investigations. And based on urine creatine panel, he was diagnosed to have a creatine transporter deficiency. So this disorder is an X-linked metabolic disease that is reported in around 130 individuals, so it's ultra rare. There is deficient synthesis of the transporter protein of creatine, and therefore this results in deficiency of the transport of creatine into the brain and the muscle. And we all know that creatine is an energy molecule. The clinical features globally, these patients are developmentally delayed. They can also have other features which include epilepsy, behavioral problems, and the majority of adult males who are untreated have severe intellectual disability, so it is thought to be a progressive disease. The diagnosis is made by an absent creatine peak on MR spectroscopy, screening with creatine panel on urine, so showing the elevated creatine to creatinine ratio, and of course, genetic testing, homozygous mutation in SLC6A8. And the treatment is actually high-dose oral creatine monohydrate in addition to arginine and glycine supplementation. So it is considered a treatable condition. And I just want to show this video to highlight the family's perspective on establishing this diagnosis. It's muted.
What is your name? Nathan. And Nathan, how old are you?
5.
Are you 5 years old?
Yes.
And how old is your sister?
One pound.
She's a bit older than you are, eh?
She bigger than you?
Yes.
Is she stronger than you?
Yes.
Yes. But you're also very strong now. What has the diagnosis of creatine transporter deficiency meant for you, your family, and especially for Nathan?
I think it's just a huge miracle that it was diagnosed. So it's an amazing discovery, and it's just for his life, it's a life change, and as a family as well, it's huge. You know, like,
Yeah.
oh, the medicine, you know, like every 5 minutes, the medicine. So there was a lot of change and time and just a new routine. But once we've mastered it now, it's done. You know,
Yeah.
And with all the treatments, it just changed his life. You know, his appetite has increased, he's more focused, he's just more engaged in everything. So it's changed him tremendously.
Because how important was it for you to hear or read that also that MRI scan or the spectroscopy showed change? I mean, what does that? You have something objective?
Oh,
next to all the.
It was just the best news ever. But
Just for the sake of time, I'll just stop it here. So we are faced, actually, we are being faced in this era with a changing face of genomics. So the traditional approach of examination, dysmorphology, paying attention to the clinical features is being replaced by this different approach, which actually starts with genetic testing, either a panel, exome sequencing, or genome sequencing. And then after you get the results, you do your evaluation. And you ask yourself, is this genotype consistent with the patient's phenotype? So this is kind of already happening, and we are dealing with this on a day-to-day basis. But we have to keep in mind, so some take-home messages, that the traditional clinical approach of detailed, comprehensive history, physical exam to build an assessment and guide investigation remains essential. Screening for treatable inborn errors of metabolism should be considered in parallel to genetic testing. And as we highlighted in the case or the patient that I described, there's a significant impact on the patient's outcome when you do this. Identifying the etiology of global developmental delay intellectual disability has become even more essential with access to genomic testing in the era of personalized medicine. So I'd like to hear thoughts from the audience, and I thank you very much for listening. Thank you.